Welcome back to the deep dive. Today, we are going to try something a little different to kick things off. I want to run a visual experiment with you.
Okay. I'm intrigued. I'm ready. Set the scene.
All right, close your eyes for a second, unless you're driving, of course.
Uh-huh.
I want you to imagine a split screen. On the left side, you've got the absolute, visceral chaos of a high-stakes emergency room.
Mm-hmm.
You know the scene. Monitors are screaming, staff are sprinting, gurneys are slamming through double doors. It is loud, it is fast, and the pressure is just palpable. Every single second feels like it could be the difference between life and death.
High adrenaline, high cortisol. Pure reactivity. Got it.
And on the right side.
The right side is a complete shift in atmosphere. It's a pharmacy archive. It's dead quiet.
Okay.
It's cool, climate-controlled, and meticulously organized. You have rows of data, shelves of catalog medications, and everything just feels academic. It's a place of long-term strategy, not immediate panic.
It sounds peaceful, but I'd argue that the right side of that screen is actually where the real pressure cooker is hiding. Really? How so? It looks so calm.
Because the person standing in that quiet room knows that the decisions they make, or, the systems they build, they dictate what happens in that chaotic room on the left.
I see.
They aren't just looking at one patient. They're looking at the survival of the entire antibiotic arsenal for the next, 50 years? It's a different kind of stress. It's the weight of the future.
And that tension is exactly where we're living today. We are exploring the collision of two massive conflicting goals in modern medicine. Goal number 1, treat sepsis immediately.
Right.
Why? Because it kills, and it kills efficiently.
Oh, absolutely. If you miss that window in sepsis, the mortality rate climbs effectively by the hour. Speed isn't just a preference. It's the only metric that matters for the patient in front of you.
But then you have goal number 2, stop using so many antibiotics, because antimicrobial resistance AMR is decimating the effectiveness of the drugs we rely on. If we use them too much or too loosely, they stop working for everyone. So our mission today is to step into the shoes of a pharmacist who is standing right in the middle of this battlefield.
I like that.
They're armed with the latest guidelines, trying to save the patient in front of them without dooming the patients of, say, 2035.
It is the ultimate balancing act. And we aren't just talking about memorizing a few rules here. We're talking about two completely different systems of thinking.
How do you mean?
One is save the life right now, and the other is save the medicine for forever. And sometimes those two imperatives they hate each other.
To navigate this, we have pulled a very specific stack of courses. First, we've got the rule book for saving our drugs. Nice guideline, NG15 on antimicrobial stewardship.
Okay, the defensive playbook.
Exactly. Then we have the brand new playbook for saving lives. Nice guideline, NG253, suspected sepsis in people aged 16 or over, which just dropped in November 2025.
And that November 2025 date is critical. This is the most current thinking we have. It supersedes a lot of the older, sepsis 6 dogma that people might be used to.
Good point. And finally, to bind it all together, we have the UK 5-year action plan for antimicrobial resistance, covering 2024 to 2029.
Which is the strategy document. So if NG253 is the tactical manual for the battle, the 5-year plan is the grand strategy for the whole war.
The war, yeah.
It's looking at how we prevent a post-antibiotic era, a world where, a simple scratch or a routine surgery becomes a death sentence again.
That is a terrifying thought. So here's our roadmap. We're going to start with the golden hour and the specific recognition logic of the new guideline. Then we'll move to the stewardship mindset. What does it actually mean to be a steward?
Okay.
We'll tackle the clinical conflict of broad spectrum versus de-escalation, which is where the rubber really meets the road. And finally, we're going to do something a bit intense. We're doing an exam cram, but not just a list. I'm going to put you through the gauntlet with 12 rapid-fire questions and 6 common pitfalls that trap people in exams and in practice.
I love a good stress test. Let's get into it.
All right, let's unpack the new guideline, NG253, as we said, published November 2025. But the title itself, it just stops me in my tracks. Suspected sepsis in people aged 16 or over. And it immediately adds, who are not and have not recently been pregnant.
Right. And for anyone listening who thinks, well, sepsis is sepsis, surely the biology is the same, that distinction is absolutely vital. Now, HICE used to be a bit more lumped together.
Yeah, I remember that.
Now they have deliberately split the guidance into 3 buckets. Under 16s, the pregnant population and this group, the general adult population.
Why go through that administrative headache of splitting them up? Is the physiology really that distinct?
Oh, absolutely. Think about a 15-year-old versus a 50-year-old. Children have these incredible physiological reserves. They can maintain a normal blood pressure even when they're profoundly septic, right up until the moment they completely crash.
Wow.
So if you applied adult criteria like, say, waiting for a drop in blood pressure to a child, you would miss the diagnosis until it was far, far too late.
So by splitting the guidelines, they're really tailoring the risk assessment.
Exactly. It reduces the noise.
Yeah.
It allows the clinician and the pharmacist supporting them to use a risk stratification tool that actually matches the engine under the hood of that specific patient.
That makes sense.
If you're pregnant, your baseline heart rate and blood pressure are totally different. So NG253 is saying, stay in your lane. This is for the standard adult physiology.
So let's say we are looking at this guideline. The big question, the one that triggers the entire cascade, is simply, could this be sepsis?
It sounds like a vague, almost philosophical question, doesn't it? But in the guideline, it's a hard stop. It's a mental checklist.
Right.
The guidance explicitly recommends that practitioners start with that specific phrasing. It's designed to break the cognitive lock.
What do you mean by cognitive lock?
Well, you see a patient, they look like they have the flu, or maybe a urinary tract infection, and your brain immediately wants to categorize it as something minor.
Sure, you pattern match.
Yeah. Asking, could this be sepsis, forces you to reconsider the absolute worst-case scenario.
The guideline mentions face-to-face assessment and evaluating risk. Now, I want to challenge you on this. A pharmacist is often not at the bedside.
True.
They might be in the dispensary or verifying orders remotely. It feels easy to say, well, the doctor did the assessment, I'm just sending the drugs.
That is the most dangerous sentence in pharmacy. I'm just sending the drugs.
I bet.
If you are checking a prescription for high-dose broad-spectrum antibiotics, or you see a sepsis order set pop up, you are the safety net. You aren't doing the physical exam, sure, but you have access to the data.
You can see the chart.
You can see the OBS, you can see the labs.
Yeah.
Your role is to ensure the prescriber hasn't skipped that critical step.
So you're basically looking for the logic behind the order.
Precisely. I'm looking at the screen and I'm asking myself, does this prescription match the story? If they've ordered the full-blown sepsis protocol drugs, but the patient's blood pressure is stable and their lactate is normal, I'm making a phone call.
Okay.
I'm asking, hey, have we confirmed the risk here? Because if we haven't, we're just throwing napalm at a campfire.
Let's talk about that napalm. The sources highlight antibiotic therapy, intravenous fluid, and oxygen as the immediate steps. We always hear about the golden hour in sepsis. Does NG253 explicitly mandate that 60-minute timer?
This is where it gets nuanced, and is where people often misread the text. You won't find a bold capitalized command saying, you must administer in 60 minutes or else.
Ah, okay.
But what it does is it groups antibiotics, fluids, and oxygen under early management and initial treatment.
So the urgency is implied rather than legally codified.
It's clinically codified. The pathophysiology of sepsis is a cascade.
Sure.
It's inflammation running wild, it's organs shutting down due to lack of perfusion. If you delay fluids, the kidneys take a hit. If you delay antibiotics, the bacterial load doubles and doubles again. The pharmacist's job here is pure logistics.
Logistics meaning what, exactly?
Meaning, how do we get the drug from the shelf to the vein? In a hospital, that process has a lot of friction.
Sure, I can imagine.
The order has to be written, verified, dispensed, delivered, reconstituted, and then hung. That can easily take 2 hours if no one is pushing.
So the pharmacist is the one who pushes.
The pharmacist is the lubricant in that system. You are the one saying, this is for a septic patient, bump it to the front of the queue.
However, and here's where it gets really interesting technically. There's a massive update in the diagnostics. We saw that NG253 was reviewed in December 2025, just a month after it came out, specifically looking at procalcitonin tests, or PCT tests.
Yes. This is the future knocking on the door.
For the listener who might know procalcitonin as just another blood test, can we go a bit deeper? Why is this specific biomarker getting a special review? How is it different from, say, CRP?
That's a great question. So C-reactive protein, or CRP, is the old reliable. It goes up when you have inflammation.
Right.
But it's slow. It takes days to peak, and it stays high for a while. It's also very, very nonspecific. You could have high CRP from a virus, a trauma, or an autoimmune flare. It just tells you something is wrong, but not what.
Okay, a very blunt instrument. And procalcitonin?
Procalcitonin, or PCT, is much more specific to bacterial infection. It's a precursor protein that shoots up rapidly within hours, specifically when bacterial toxins are present.
That's a huge difference.
It is, but the real magic of PCT isn't just that it goes up fast, it's that it comes down just as fast.
And why does that matter so much?
Because it tells you when to stop.
Mm.
If you start antibiotics and the PCT levels crash within 24 hours, you know the antibiotics are working. But more importantly, if the PCT stays low from the start, there is a very high probability that this isn't a bacterial infection at all. It might be viral.
So it's a tool for confidence.
Exactly. It gives clinicians the confidence to not prescribe or to stop prescribing early. That is the absolute holy grail of stewardship. It moves us from guessing and hoping to measuring and deciding.
Which is the perfect segue to the other side of our split screen. We've got the speed of sepsis. Now we need the control of stewardship. Let's look at NICE guideline NG15.
Right. NG15 is the rulebook for the archive side of your screen.
When I hear stewardship, I honestly picture someone, guarding a castle. It sounds so defensive. None shall pass.
That's the old school view, the antibiotic police. But NG15 defines it very differently. It calls it the effective use of antimicrobials to slow the emergence of antimicrobial resistance.
Effective use, not no use.
Exactly. Notice it says effective use, not no use.
I think that's a common misconception. People think stewardship just means refusing to dispense drugs to save them for later.
And if you refuse to dispense a drug and the patient dies of sepsis, you aren't a steward. You're incompetent. True stewardship is about systems and processes. NG15 breaks it down into antimicrobial stewardship programs, prescribing systems, and introducing new antimicrobials.
It sounds like it's trying to remove the individual error or the individual decision from the equation.
It is. It's about building a system where the right choice is the easiest choice. Why do doctors prescribe broad-spectrum antibiotics when they aren't needed? Often it's because the local guidelines aren't accessible or the order set on the computer is confusing. NG15 puts the responsibility on the organization to fix that infrastructure.
And this isn't just happening in a vacuum, is it? We have this UK 5-year action plan for antimicrobial resistance running from 2024 to 2029. I looked at the map and the source material. This is a 4-nation strategy.
It has to be. Bacteria do not respect borders. You can't have a great stewardship program in England and a terrible one in Wales because the resistant organisms will just, move. The source details explicitly state this is a collaboration between the DHSC, the Scottish government, the Welsh government, and the Northern Ireland administration. It's a One Health approach.
What do you mean by One Health?
One Health means recognizing that human health, animal health, and the environment are all inextricably linked. Resistance breeds in agriculture, in sewage, in hospitals. The 5-year plan is trying to coordinate all of that.
We're currently in 2026, so we are slap bang in the middle of this plan. The source mentions a 20-year vision. What does that vision look like? Or maybe, what are they trying to avoid?
They're trying to avoid the post-antibiotic era. Imagine a world where a hip replacement is too dangerous to perform because the infection risk is, say, 50%.
God.
Imagine where chemotherapy is impossible because we can't protect the patient's compromised immune system. The 20-year vision is to contain AMR so that modern medicine remains viable.
That really puts the pharmacist's daily grind into perspective. Every time you intervene on a prescription, you aren't just, annoying a doctor.
No.
You're holding the line for that 20-year vision.
You are the boots on the ground. The 5-year plan is a PDF on a government website. The pharmacist is the one actually executing it, one prescription at a time.
Okay, let's get to the friction point. The moment where these two worlds collide, we have sepsis speed from NG253 demanding immediate action and stewardship safety from NG15 demanding caution. In practice, this manifests as the concept of starting broad.
This is the daily dilemma.
So what does start broad actually mean in the trenches?
It refers to empiric broad-spectrum therapy. When a patient hits the ER with suspected sepsis, we don't know what bug they have. It could be E. coli, Pseudomonas, Klebsiella, strep. We have no idea.
So we use a carpet bomber.
Exactly. We use a drug or a combination of drugs that kills everything. We cast the widest net possible because if we miss the bug, the patient dies. NG253 essentially gives you permission to use that sledgehammer in the first hour.
But the stewardship side of your brain must be screaming. Broad-spectrum antibiotics are like ecological disasters for the body, right?
They are. They wipe out the gut microbiome. They select for the most resistant, nastiest pathogens to survive and take over. It's like nuking a city to catch one criminal.
You get the criminal.
You get the criminal, but the collateral damage is immense.
So how do we resolve this? You can't not treat